Thanks to both Dave and Thanos for joining me today on this episode. We got a great show ahead of us, and so I'll start with an introduction, and then we'll kind of jump right into it. Dave is a dad, an engineer, an athlete, an entrepreneur, and a human who believes we create our own futures. He's been incubating his current enterprise for several years now, and we've caught him and his partner on the verge of launching their minimal viable product to the world. Thanos is an emergency medicine physician and clinical informatist. He's dual board certified in emergency medicine and clinical informatics, and he spent the last 10 years working on systems interoperability and physician workflow improvements. He's an associate professor at the University of Pennsylvania's Department of Emergency Medicine, and he's also the co-founder of QiiQ Healthcare. To start off, I'm wondering if I can get both of your perspectives on, what is QiiQ and what problem is it really aiming to solve?
QiiQ is an enterprise, an attempt to build something that will improve workflow in emergency care, specifically in the hospital. It was born out of an interest in really eliminating or at least reducing the problems that we all know so well as patients anyway, either for ourselves or for loved ones, where we've found ourselves sitting in a waiting room, unsure of when we were actually going to get the attention we strongly desire. And these days, especially with COVID, it can feel, even more toxic and unsettling to be sitting in a waiting room. And then, of course, usually one is suffering in some fashion, sitting in that waiting room. It's so obvious a problem to solve. And because it's existed for so long, it was clear right from the start that this was not going to be an easy fix. Because naturally, of course, lots of people have confronted this issue. And, if nothing obvious and profound has altered that landscape by now, then we had our work cut out for us. And so I knew going in right at the beginning, more than 4 years ago, that this was going to be a bit of a slog, that it just wasn't going to come overnight. Of course, no startup wins overnight.
The problem that you guys are addressing is huge in and of itself. So never mind trying to come up with a solution that makes sense and that's actually very useful, but it's a challenging problem to begin with. It's not it's not a simple we're looking for an app to get people to come together to have dinner or something like that. No, this is actually has potentially life-saving implications in a very dynamic, very complicated work environment.
Yeah, it's not a photo filtering tool or photo editing. It's this is a big, wicked problem in contemporary society, and it affects everybody. And of course, and Thanos will speak more to the specifics, but when I first started, before having met Thanos, there was this giant chasm of problems. It manifests as one negative experience for a patient or the loved one of a patient, but it's like, what are the elements that create this end result? The more you dig, the more apparent it is. There are a pile of things that combine to create this end result of long wait times. So not only is it a wicked problem, it is a pile of smaller, some intractable problems. So it was really a process of discovery for the longest time, experimenting with different ideas to address it, and coming up with ideas that indeed have practical use, but didn't necessarily hit the nail on the head. So you might say we've been on a road of many pivots, starting with focusing first on a particular disease state, sepsis or STEMI heart attack, but over time realizing, well, it's not just about addressing a particular disease state. It's about looking at the process and addressing the process. And furthermore, not to monologue too long here, but it's really a challenge to choose the particular constituency whose primary issues you're going to tackle first. So there are a whole bunch of people that work together to deliver care in the hospital, in the emergency department. Every one of the stakeholders or participants, including the patient, has a role to play of some kind. And for pretty much everybody on that stage, there are things that get in the way. So over many conversations and a great deal of analysis and thought, as a group, it became more and more clear what we needed to do. And then one fortunate day, I met Thanos. And Thanos, I'll let you speak to what had been burning for you that led to your part in this play.
Dave, you definitely you touched on a couple things. We'll definitely circle back to those things. But yeah, to your point as well. So Thanos, you're bringing in that the heavy clinical medical background. Love to get your perspective on the types of problems this company is really solving. And then also really curious how you guys ended up meeting. I mean, you're coming from different backgrounds, different areas of expertise. How'd that happen? Was it just a coincidence?
Just to speak a little bit to the first question, I think Dave mentioned a very key element, or what we end up seeing, or at least from the patient's perspective, is just how long patient care takes. And really, their perception is that a doc comes in, it's the time it takes for them to actually see the provider is one of the measures that they hold as a quality indicator for the patient. And if it takes too long to see the doctor, or if it takes too long that they're in the ER, they're seeing that as the only metric really that may gauge their actual healthcare experience there. But behind the scenes, there's so many moving parts, so many little things that add up to an increased length of stay and the quality of their care. And really, the things that I've been looking at for the years, as far as our inefficiencies in the department at several different hospitals, I mean, they all add up to these increased lengths of stays and delays in care, and it ultimately affect the patient's satisfaction and perception of their care. So we're really trying to tackle that one, big problem of inefficiency, but in the end, it's improving, the patient's experience as well as the provider's experience.
Dave, you're on the Canadian side. Thanos, you're in the U.S. right now. I mean, obviously we hear a lot about length of stay being an issue going through the emergency departments. On the Canadian side, that being where I come from, is it the same kind of conversation in the U.S.?
Many conversations on length of stay, and a lot of those other metrics, from door to triage, door to provider, door to disposition. I mean, there are a lot of different metrics that we look at, but length of stay is one of those big ones because it's ultimately what the patient's experiencing, and it closely tied to their satisfaction and experience in the department.
No, this is not a problem limited to national borders. Canada, the US, UK, India, everywhere in the world, everywhere there is a hospital, addressing or delivering emergency care, pretty much almost without exception, this problem exists. Mm-hmm. Why? Why is that? Why is it so dominant? Why does it exist pretty much everywhere? And why hasn't it been solved yet? I mean, that is an incredibly compelling question to ask. And of course, for those who are able to provide a solution, the market isn't just the US or North America. It is a solution that can be delivered worldwide. And that makes it extremely exciting for us. Mm-hmm. Okay. We get to change the world if we can make this work.
Big lofty goals, definitely a really important part of startup culture. So I can certainly appreciate that. And I believe it's also part of your mission and vision, which I'll get to in just a moment. But now also, again, really, really curious on this topic. How did the two of you end up meeting? Was this like a meeting of the minds? Was it a conference? And how did you decide this was something, of mutual interest to that extent that it's a global issue and that you really wanted to work together to solve it? How did you guys do that?
I know that I was perusing I believe this was the AMA's Innovators Network. I believe that's the channel that we met on. I think there was either a conversation or a posting about the topic of improving efficiencies, and it was something that I've been working on myself to some capacity. And I think we just started talking, sharing ideas, and it wasn't even. I don't think the intent was to partner initially as much as it is to have the conversation about, our ideas. I think he was curious from, my perspective as a ED doc, and I was curious about his perspective from, his experiences over the years with QiiQ. So I think that's how we initially started having the conversation, and then it was just a natural partnership for accomplishing what we both had in mind.
Another interesting thing to note is that, it wasn't at first about building the particular solution we're fielding now. I think at the beginning when you and I, Thanos, were talking, we were looking at a broader swath of problems and potential solutions. And we were looking at potentially sort of optimizing staff levels for current demand. Looking at the whole delivery machine of many people and what all of the actors would need in terms of coordination. But it was more about an analytics strategy rather than kind of the behavioral, I hate to use the term behavior modification, but it's ultimately manifest that way, and providing a tool that allows a particular stakeholder to work differently, to work more efficiently.
I think it's interesting that we started off with that staff leveling tool because we were looking at the problem from we don't have enough resources, or the resources are poorly allocated. But the more we dug into the underlying problem, it was realizing that it's not necessarily how many people you throw at it or the right number of people. I mean, that is part of the problem, but it's also how efficiently these people are able to do their jobs. And the underlying problems aren't like, throw more people at it. It's just allow them to do their actual jobs and to do them efficiently.
Reducing the friction of delivering care and choosing which, like really thoughtfully choosing which friction to remove or set of frictions.
From a practical perspective, there's the aspect of, reducing wait times, increasing efficiency of existing resources, while also not, adding burden to the, already overburdened, I guess, staff within the emergency department. So from the perspective of QiiQ itself, how does it work? I mean, ultimately, what is it? What's the tangible part of QiiQ? How does that function?
The main delivery of our product is a mobile application, and it's not supposed to replace the EMR. It's supposed to sit on top of the EMR, and it's a key point. And part of that is because there are inherent inefficiencies in the EMR that come along with each task that we want to perform. And every time you want to perform a specific task in the EMR, it requires a shift in what you're doing. So there's no true multitasking. Humans can't multitask. We just task switch. And every time you do that, there's some inefficiencies just as people. And there's inefficiencies in software as well. And we're trying to reduce some of the friction really in task switching and improve safety and efficiency by doing that. So when we have an app that performs some of these functions that we have in our program, everything from looking at your patient list to looking at results to charting, writing your note, dictating. Those are like the fundamental tasks, but then it comes to these one-off tasks that sometimes we're trying to switch tasks right in the middle of what we're doing, and it allows you to use natural language processing to quickly perform that task without completely shifting your train of thought, which is what we find actually increases errors and decreases efficiencies.
From what I remember, I had a chance to work a few years back doing operations type research in a few emergency departments, and a lot of the things that you're mentioning, it sounds very familiar in the sense that from what I recall, there would be essentially little kind of workspaces or stationary mobile kind of units that as a staff member you can kind of carry with you as you go from station to station, but you're always entering information. There's a lot of manual data entry, data input in an emergency department situation or environment. And so you've got the walking around with these stations aspect of it. You've got multiple sources of data entry. It's very hard to do things on the go. It's very hard to be very alert and very responsive to things that are happening while also maintaining the admin aspect of all of that. So so QiiQ itself, is it tapping into that? Is it really addressing that, I guess, operational inefficiency, we might call it?
Yeah, that's one of the primary challenges that we're facing, or not we're facing, we're addressing. So you don't have to lug around a workstation on wheels anymore. You have a powerful computer right in your pocket that you can use to perform all those tasks. And we've looked at the typical pattern for an ED doc is to actually go from again, there's different models, but one of the most common models is to sign up for a series of patients. So it could be 2 or 3 patients at a time, depending on how busy it is, and then to go in series into patient first room, see the patient, do your exam and whatnot, go to the second room, and then the third room, and then go back to the workstation. So you're consolidating your work at the computer, and you're doing it at a fourth location. So there's a delay between the first patient that you're seeing and the time that you're placing your orders and doing your documentation, because you're trying to get some form of efficiency. You're as a physician, you're trying to be more efficient, but the system itself is inefficient just by doing that. There's delays that you're creating by doing that. So one of the solutions that health system kind of came up with is, put a workstation in every room, or bring a workstation with you, but then you have to log in every time or carry around a computer on wheels, and that's not really feasible at times.
Expensive. I mean,
it's very expensive, sure.
St. Paul's Hospital in downtown Vancouver went this way, with workstations on wheels, and it's amazing to be in there. There are so many workstations everywhere. It's like, this is a tripping hazard, and it's definitely a spatial navigation hazard. It's everywhere you look there, or everywhere you want to go, there's a workstation on the road.
But one of the challenges with that is that you actually look at, depending on the IT implementation, logging into one of those workstations can take anywhere from 30 seconds to 2 minutes, which may sound trivial, but it's also a deterrent. So if it's taking me 2 minutes just to do a cold login into an EMR in another room, I'm not going to log into that computer, so I'm going to revert to my habit of waiting and batching all my work at a workstation when I'm done seeing all those patients. So we're addressing that directly by bringing a lot of the functionality to your pocket. So there's no longer that repeated login at a workstation, those delays. We're using security EMR logins right on your phone to perform a lot of those tasks, and allowing you to actually do them without that delay.
A good thing to underscore here is that, one, it's not eliminating or replacing the EMR,
right?
It's augmenting it. It's also worth underscoring how, even while you are logged in to an EMR, let's presume that you've got a workstation on wheels with you in the patient encounter. Just because it's there doesn't mean that it's going to get you what you need or allow you to, document what you need as quickly as you could do it on your phone. Like, the phone's just going to be faster. Side by side, both devices logged in and ready to go. EMRs are not built for rapid navigation. Just by virtue of the way the EMRs are designed, it hasn't been a driving design priority. I'll tell you just a quick story. I broke my arm mountain biking a few weeks ago, ended up in Mount St. Joseph's Hospital here in Vancouver. And as I sat with the triage nurse, I just asked her a few general questions about, the new Cerner system that they're using. And she talked about how when they were using Allscripts Sunrise, she could get a triage session done in 2 to 3 minutes. And now with Cerner, because of all the buttons she had to click, or all the boxes she had to click and all the fields that she had to fill out, now she was up to over 10 minutes per patient. And hey, it's what they got to do. This is critical work. It's part of the process. You can't skip it. You can't scrimp on it. So she had to live with an extra almost 10 minutes per patient on triage. And as I probed and asked, questions about her experience working with it, I could hear the frustration because she had known what it was like to be able to do it so much more efficiently in a prior IT environment. And that is not a knock on Cerner either, right? It's just Cerner is built to achieve certain functions. They all are. And the priority function that they're centered on is not ease of use for the clinician. The design priorities are other things. So Cerner does a lot of stuff. It's a powerful system, as is Epic and Allscripts and Meditech. So, these are incredible companies that create an incredible and sophisticated product. We're just trying to help those systems be more useful.
I'm going to really simplify it for a second here, but what I'm essentially, if I can draw an analogy, it'd be the same thing as, you're relying on existing systems, much like developers rely on the iOS platform or the Android platform or whatever, but then they can develop very specific targeted solutions that are then deployable easily through that platform to a lot of customers, essentially. And so this mobile ER, ED type assistant, do you imagine this being deployed on every physician or every healthcare staff member's phone? Are there any kind of technical challenges around doing that sort of thing in terms of privacy, or how would this work practically?
First, deployability. A lot of that depends on the institution's policy on mobile devices. So if they're already using mobile devices, then it's a device managed by the health system. It really depends on their privacy and security policies. So if it's a device that's managed by them, then it's secured by the institution, and the same policies apply to our software as well. And you can lock this down as much as requiring to be on the health system's network in order to access the data, or requiring. Regardless, you require the EMR credentials to log in. So it's leveraging the EMR's same EMR security requirements. On top of that, there's additional device security and privacy, which is I'm trying to really simplify. I'm having a little bit of a hard time. There's a lot on that topic. We could just talk about security and privacy on these devices, because that is a huge point. Because we want to create a platform or a product that addresses that big concern. And rest assured, that's on the top of our priority list. So we are leveraging the EMR security features, as well as promoting the healthcare system's device policies. And I mean, we have recommendations obviously to ensure security, but ultimately it comes down to the health system to ensure that their users aren't going around giving off their phone to someone else while they're still logged in and allowing them to use
I
it.
mean, nowadays, to your point, I mean, realistically, there's so many companies, right, that are giving out company cell phones and that have a lot of, quote unquote, kind of confidential work-related information, and it's really it's up to the employees and their policies to kind of, take responsibility over that. But then there's also a lot more options I'm seeing nowadays where if you've got a personal cell phone, you can there are applications where you can just download them on your personal cell phone, and then while you are doing work-related stuff, even on your personal cell phone, um, then you're allowed to do that. And so it's really just a matter of kind of managing, the extent to which you can have access to, work software, what have you, while you're on your personal phone. But I mean, there are solutions already out there. I mean, this is not like a brand new thing, and so it's really just a matter of, I guess, working closely with your customers, your clients, figuring out what shape and size how exactly that's going to look. But the deployability is it's definitely possible, regardless of company issued or health system issued cell phones, and whether those are available to all physicians versus if they have to rely on their own personal cell phones. Is that right?
You can use this on any device, whether it's personal or company provided phone. No health information is stored on the phone. I mean, that's a key element. So you can, uh, if you log out, there's no retained information on the phone, so there's no risk for leakage if the device was to leave your hands. I think the key point though that I really want to make was uh, the hospital policy on if it's bring your own device versus a device that's provided by the health system is that they could institute their device policy with remote management. So for security and requiring everything from lock screens to passcode, how hard a password requirements are. There are many features that you could require to ensure that the device itself is secure. But in the end, you still have a password for the EMR that you need to know and log in order to use the software, even to get to the patient data, which is much like if someone walked into the hospital and knew your password, they'd have to log in at the hospital. So you can lock this down as much as you want, but uh, someone that's not really careful could inadvertently cause problems. But we try to minimize those situations by providing recommendations.
And you're right. It's the whole privacy space is a huge topic, but
Man, yeah.
and really interesting to get into separately, and the solutions that you guys are building out to again make this as deployable and as useful as possible
Right.
to physicians in real space, real time, in an actual clinical setting. So love to get into that. There's a couple other things we want to cover today, but that's an awesome separate conversation. So at this point in QiiQ's history, it's been around for a few years, going through clinical development, R&D, and actually developing the platform itself. I know on the company website there are a few kind of demos, and there's also a section where for anyone interested, you can actually sign up for a beta right now. So I know you guys have your MVP, and I'm just wondering if we can just go into that a little bit. At what stage is the company at, and what are you looking to do in terms of testing this thing out?
We have been in an R&D phase for a pretty long time, and we've needed that time. But we're now approaching a new phase in the company's progression or life cycle. The MVP, minimum viable product, prototype, the first version is to be deployed, we hope, in 3 different hospitals, where we would count on users, physicians, and the other people sort of in the, let's just call it in the field of work, around the emergency physicians, would contribute a ton of feedback, so that we can learn from all of that feedback and make the next generation of the product much, much, much better. And so we're in talks with a number of health systems now in the hopes that we can get 3 pilots going in 3 different emergency departments. We hope and presume within 3 different health systems, so that we could be sure that it won't just be an Epic environment or just a Cerner environment or just Meditech, that we could sort of be an add-on to any one of the big EMRs. But the most important thing for us to do now is to learn from users, to have them show us where we're getting it right and where we need to, add some improvements. So we're looking forward to that, and that process is we're in discussions right now with several, and hopefully into early 2021 we'll have both an array of really positive testimonies from a bunch of physicians, again, in different health systems, as well as the evidence that this product is actually making a difference in workflow, as manifest in throughput numbers, for the emergency department, or left without being seen percentages, or length of stay, wait times. The metrics that departments actually measure their how effective they are. So in other words, we'll attach to those same measures in trust that we'll make a difference we'll help them make a difference on their critical metrics.
So yeah, this is an interesting point, because I was going to follow up with, what kind of, say you run a few of these pilot studies, what kind of metrics are you really looking to achieve? And is there, I guess, are there already benchmarks for these kinds of things? And B, are these metrics, I mean, it's one thing to address key metrics that are important to clinical staff, but how do you also go beyond that to address what's really important information for the hospital systems to actually, what's going to make a compelling case to them to just be completely on board with taking on this application?
That's a really good question, Dorian. The physician, and Thanos could speak extensively to, the challenges of being an emergency physician in a, high volume department, how stressful that can be. And we've seen lots of data about burnout, how bad burnout can be in some cultures and some hospitals. So that's a number that we're going to try to influence, is if there's any reasonable and reliable way to measure burnout. But that's the clinician's experience. And Thanos, I'll let you, you can speak to it much better than I could. But
interesting point. Yeah.
For the administrator, they're running a business. I mean, maybe not so much in Canada, but certainly in the US, it's a competitive marketplace, and they're trying to keep their hospital in a sort of an elite status position compared to the hospital down the street. They're competing for customers, you might say, and they have to run a good shop, and they don't like patient waits, so they definitely want to get that down. Having minimal wait times and high patient satisfaction ratings is a huge competitive advantage. And throughput is a measure of basically how many patients are running through the department on a daily, weekly, monthly basis. And of course, our goal in part would be to help improve those throughput numbers, not to add more load to any one healthcare worker in that emergency department, but to allow all of the people ultimately that are delivering care to work more happily, more efficiently, less stressfully, yet achieving higher capacity, allowing the hospital to generate more revenue. even while the staff are happier. I mean, that's an exciting challenge, difficult balance to strike, but every hospital has the objective of not burning out their staff, but yet being able to support higher and higher numbers of incoming patients without having them get frustrated and walk out the door without being treated, which is a very bad thing. Patients will often end up going home and they're not treated, so they'll sit at home, and in some cases they'll get sicker and end up being a much larger expense to the healthcare system overall, or to the insurance companies that are paying for their care.
To speak to a couple of the, what you asked about benchmarks is like, yeah, we actually look at several of the benchmarks, and it's not just length of stay. I mean, I think I mentioned a couple of the other ones, from door to provider times. Provider to disposition is a big one. So that's basically the time that the provider has signed up for the patient and the time they've made a decision on whether the patient is either getting admitted, discharged, transferred. And there are those are actually analyzed from usually on a department level from different health systems. So everyone's pretty much aware of their own metrics, and we do compare each other across the board. And unfortunately, but unfortunately, that doesn't also tell you the quality of care you're getting, but it is a measure of performance of a department. And we're actually looking at comparing the installation and post-installation metrics to determine the impact that QiiQ can have on a department. So we'll be directly looking at some of these measures. Overall, length of stay is a big one, but one of them is the provider to disposition, because that is something that is very provider dependent. So it doesn't matter that if you've already been admitted and you're waiting for a bed, you're still in the department. So your length of stay in the department is still long. So we're looking at specific metrics and seeing how we could improve those. And based on the feedback and the analytics from the usage, we were able to look and fine tune what is it that people are doing that is taking too long, and how can we improve those tasks. Like one of the ones that we're looking at is even the notification time and the acknowledgement of notifications of results. So how long does it take for a provider to know that a result is back, and then is it actionable? So how long does it take them to perform an action in response to that? And that could directly affect patient care, such as getting back a data that supports sepsis. It's like, what is your door to antibiotics time? That's directly affected. So there are a lot of these specific indicators that we have a list of the ones that we want to look at initially. And of course, that's going to grow over time, but there is data that we want to collect and analyze and make sure that we're on the right path to improving all of those.
On this point of data, collecting data and analytics, so on the one hand, the assistant itself is not meant to collect information from EMRs directly, let's say, but the platform itself will be able to collect information that's useful from your company perspective, from QiiQ's perspective as well, as the kind of information that your customers would be directly interested in having. So I wonder if you could speak a little bit to that. What kind of information will be collected, and how might you be able to use that?
Collecting patient data, right? So it's not like, that this patient's here for, or any of that patient sensitive data that's not what we're collecting. It's the user events that are important. So it's the notification times and the actions and the when they signed up and their dispositions. Like all that data is what's useful in analyzing the performance of the provider and the patient flow through the department. So those timestamps. Again, it's not specific. I'm sorry?
I was just curious, the thought popped in my mind, but referral times as well, admission times, that sort of thing?
So you could extrapolate the time that you made your decision for admission and then the time that they left the department. Unfortunately, that time is not so much dependent on the provider it helps you on the back end. Like later on, looking at that data is very useful, right? Like seeing why is this patient in the department so long after they received their disposition, you know, they're admitted. You could look at that. And unfortunately, it's not like anything that the provider is doing differently. It's more of the back end.
Right.
So they could definitely use that data as for analysis of their inpatient side. But we're directly looking at what's going on in the department to streamline and improve their the patient flow.
Dave, did you
What?
chime in?
Yeah, I was going to say one of the sort of data elements that really struck us was how little of the shift of a clinician is actually spent on direct patient care. In other words, how much time is the physician actually, you know, bedside or directly working with or engaged with the patient? And that percentage turned out to be 25% or even less, which really it depends on the patient, of course, and the clinical situation. But, you know, I think most clinicians get into this line of work because they want to help people. And very often end up complaining that they're spending so much time on documentation work, sitting in front of a screen or standing in front of a screen on a workstation on wheels. But, you know, that is not the activity that drew any of these incredible people into this line of work. And yet here they are spending sometimes close to 75% of their shift time doing documentation related stuff. So for us, it'll be important that we see those numbers shift, potentially to reverse, where a clinician is able to spend way more time on direct patient care and way less time on documentation while still getting all of the documentation related work done more effectively. So that's, again, that's a driving force, and it's an exciting thing to chase.
Yeah, and that directly correlates with like that burnout that Dave was talking about before. I mean, if you're spending the 25% of the entire patient visit, like the amount of time you're spending overall on the patient, including the charting, calls, consults, orders, documentation, like all of that is bundled in there in the 100%, you know, the patient visit time. If you're only spending the 25%, it's not saying that it's not enough time. It's just a disproportionate amount of time that you're spending on direct patient care. So if you improve the systems that are increasing that other 75% time, then I think we're doing a good job. You know, if we're reducing or balancing out that equation.
A little bit about this idea of patient satisfaction, but also provider satisfaction, job satisfaction, work satisfaction, and so on. And I'm wondering, you know, patient satisfaction could obviously go up. I would expect it to anyways if they're spending as little time as possible in an emergency department and, you know, basically just getting back to feeling better as quickly as possible, whatever that might mean, diagnostic tests, you know, referrals to other departments, admissions, and so on. So is that, obviously it's a very important metric. I guess I'm wondering two things. Is that also one of the things that you're planning to incorporate into the pilot studies? And two, and this is probably the bigger question, to what extent do hospital administrators, anybody that runs these hospital systems, whether it's for-profit or public, not-for-profit, to what extent do they really pay attention and sort of consider them, you know, actionable pieces of information?
Patient satisfaction is huge, right? I mean, that's it's a lot of what we're talking about right now, and administrators are definitely aware of the pressures that you know that patient satisfaction can have on the health system, including reimbursement now. So, I mean, who doesn't want to go home faster, right? Like, who wants to stay in the ER longer than they need to be? So. I think we're directly addressing patient satisfaction by reducing those metrics of total length of stay, door to provider, door to disposition. That'll definitely address one element of the patient satisfaction, but hopefully by improving those times, you're also improving outcomes. That's to be determined, obviously, and that's part of our goal, is to look at how much does the improvement of these metrics affect the overall outcome. That'd be a very interesting data to analyze. And I think, in the end, yes, it's the perceived satisfaction, but it does affect their care overall. So it's a healthcare delivery.
This is the sort of thing that a lot of different stakeholders are interested in. This is not just a, whether you're a clinician, this is of interest, a researcher of interest, a hospital admin of interest, reimbursement companies are interested in this sort of information. So you can imagine this being a really important thing to track over time, as QiiQ itself is sort of incorporated into more and more hospital systems.
It's deeply satisfying to be working on something that can positively affect pretty much everybody in one way or another. We've all had, let's say, exaggerated visit times at hospitals, and I've personally both seen the execution of assessment and treatment protocols produce great personal experiences for me, where I was amazed at how effectively and how generously and how quickly I was assessed and treated. And I've also been through the opposite experience, where it's like, oh my God, this is terrible. And it's not the fault of any one of these people running around trying to take care of me or all these other patients in here. This is a systemic issue. So, and everybody cares about producing a better result. The insurance companies, the frontline workers, the administrators, everybody wants the same end result that we're pursuing here. So, and I would add, there are other vendors in the ecosystem of technologies and infrastructure contributing to that care process, right? The EMRs, for one. We would expect that if we're successful, they too will be more successful. So it just feels like if we execute, if we succeed, everybody else does too. There are no losers.
That's a powerful point. I was going to ask you what, from all of the R&D work and all the development that you guys have done so far, what's been an important, driver of your interest and passion in seeing this through, making this happen, whatever needs to be done, just getting it done. Is that personal aspect of your experiences having gone through the emergency department, your loved ones, or any of that? Is that a key driving factor to what you guys are hoping to accomplish?
I have a professional interest in this just because it affects what I'm doing. I've been dealing with this problem professionally for over 10 years. So I know what it's like. I know how this will impact what I do and my colleagues. It's been a topic of conversation for way too long. So it's one thing to sit at the sideline and just wait and hope that things will be improved over the years, but it's another to actually try to affect change. And I think that's what's exciting and drives my passion to make this, make this come to fruition. Mm-hmm. Because ultimately I want to be the end user for this.
What are your colleagues saying about this, about the company, about QiiQ?
They like specific features that they're super excited about. So it's funny to actually put this in their hands and see what their response are, what the response to specific features. And it's the variability is what's interesting. Some people just like the natural language processing, the voice, which is, it's great. You get to pull up, like I could ask a specific question and it gives me an answer without having to, go through an EMR and drop downs and OK buttons and whatnot. It's just very, very fast. So that's one feature that people like. And another, it could just be the documentation, simply being able to dictate, and then order entry is such a huge thing for people. I mean, that just lights people's eyes when they see that feature. So again, it just varies on who's looking at it and what problem they find and relate to the most. So it gives you a little bit of insight in what people's gripes are about the EMRs.
Sounds like a lot of positive feedback. I'm glad folks are informing the development process as well. I know you guys had mentioned that a little bit earlier. It's going to be very end user driven going forward. Okay, perfect. And Dave?
I have, of course, a very different professional relationship with the end result of creating this product. There is a heavy personal motivation for me. I had an experience with a very, very close friend about 10 years ago who got really sick without being sort of tagged as a sepsis alert. She was in an ER. I took her to an ER, to an emergency department in a Canadian hospital. She was in terrible shape, but she was very quiet and serene, suffering quietly, I should say. And, they put her on a stretcher in a hallway in the ER because they had a lot of very noisy and, let's just say, loud, protesting patients to handle, to essentially calm and deal with. And my friend was basically left to slowly worsen. And after about 6 hours, she went into, she was in septic shock. She went into cardiac and respiratory arrest. And it was merely by good luck that somebody noticed there is something wrong with this person. And very quickly they got her into resuscitation, and she ended up being okay. But that experience was so incredibly distressing, in part because I knew darn well that this unfortunate circumstance could not be blamed again on any one person, because everybody in that department was busting their butts. So why does stuff like that happen? Mm-hmm. Well, it's a problem that's fixable. It's not just about technology. It is a cultural thing too. And there is a matter of adoption, right? We can build the greatest tool or the greatest solution, but unless there is, let's say, support and endorsement, and therefore adoption of the tool, then it's useless. Anyway, it feels darned exciting to be building something that could potentially reduce or even eliminate, for any other person like me and my friend who went through a living hell, not just that night, but for months afterwards, where something like that may not happen to them and to many others eventually. So, I mean, it's pretty easy to wake up in the morning when you're addressing something like that.
Brings everything back to how we started off talking about what's the real value in doing this kind of creating this kind of software. It has huge implications, not only for practicing professionals, but also for actually saving lives. And I think that's one of the many unique things about it. Not to mention, and I don't think we had a chance to touch on this yet, but it's a cost-effective, very easy to use and to implement, and very useful solution. So I love that about it. You guys have done a lot of incredible work, and I know you have pilot studies coming up and an MVP to actually use in those studies. So I do wish you guys all the best through that process. I'll turn it to you just to get the last word in, both Thanos and Dave. If there's anything else we haven't touched on that you really want to speak to, and then we'll just wrap it up after that.
I think Dave kind of reflected the sentiment there, that we're really excited make this successful, and specifically because these problems we're addressing. So I think we're reaching this next big milestone for our company, and it's an exciting time. So I'm really keen to see what we are able to accomplish with this product.
You know, we're a small team. We're busting our butts to try to get this into the world. We really need hospitals who are interested in giving this a trial run to come forward, or any individual physician that is intrigued by this. Please get in touch, and let's try something. Let's see if we can make a difference for you. And I'll add one little plug. We're about to raise a little bit of money. So if anybody is interested in sort of coming forward and helping us make that happen, we would certainly welcome those conversations too.
We'll include contact information and a link to your website as well in the description. So for anybody and everybody interested in following up, they'll be able to reach you guys directly. Add a tag to your social media pages as well. All right. Well, it's been awesome getting to know both of you and hearing your story and what you hope to accomplish with the company. Again, I wish you guys all the best. I see a lot of fantastic things coming from QiiQ through the next couple of months and years as it gets deployed into hospital systems, hopefully around the world, to address problems around the world. And crossing our fingers, yeah. And again, I wish you guys all the best. Thanks so much for joining us this afternoon.
And thank you, Dorian, for committing to doing this and really engaging. It's been a pleasure.